So our next clinical correlation is entitled Sinus Rhythm and Variations, and essentially we're going to look at a case of sinus rhythm gone awry and then variations that you might be quizzed on the boards. So here's case 1. Mr. Smith is a 93-year-old male with hypertension and osteoarthritis. He was in his usual state of health until approximately 1 to 2 months ago, when he started feeling dizziness and lightheadedness intermittently. He says that the symptoms are not positional, but they do worsen with increased exertional effort. He also notes that he passed out last weekend while mowing his lawn on a hot day. A recent echocardiogram and carotid ultrasound were normal. He was evaluated in the ER, and the blood pressure is stable at 100/60. Respiratory rate is 18 per minute, and temperature is 98.6 degrees Fahrenheit. ECG shows the following. So take about 15 seconds and look at this. So the question is, after stabilization in the ER and admission for telemetry monitoring, the next step in clinical management would be A, mitidrine and compression stockings, B, beta blocker therapy, C, pacemaker placement, D, implantable cardioverter defibrillator, or E, cardiac catheterization. And the answer is pacemaker placement. So if you look back at this ECG, you'll notice that we have a sinus bradycardia and the first half of the ECG. And then take a look at the second half. You notice this huge gap in between. And really what this is a 3-second pause. And you can see a P wave and a QRS wave. And the QRS is outlined with the first blue arrow. And then we have a 3-second pause. And then the next sinus beat comes in 3 seconds later. So currently the guidelines state for a permanent pacemaker, if you have sinus node dysfunction, a permanent pacemaker implantation is indicated for sinus node dysfunction with documented symptomatic bradycardia, including frequent sinus pauses that produce symptoms. So he has symptoms, he has frequent sinus pauses, and he has an indication for a pacemaker. So here's the second case. Ms. Allen is a 48-year-old female with obesity and borderline insulin resistance. She recently went to a health fair at work and received blood work and an ECG. She was told that her ECG was abnormal, and she was told to follow up in clinic with you. She reports that she's been feeling well and has recently started an exercise program through her employer. She denies chest pain, shortness of breath, and palpitations. Her ECG is shown here. So a couple things about this. Notice a precordial progression backwards. So if you start in V6, you see a tall R wave, and then that R wave gets progressively less versus the S wave over time. And then you can also notice an inversion in leads 1 and AVL, which is to say that you have a deep S wave and a smaller R wave. So based on this, the next step in the patient's management includes A, reassurance, B, a right-sided ECG, C, a chest x-ray and ultrasound, D, a transesophageal echo, or E, an exercise stress test. So the easiest thing to do is B, a right-sided ECG. So we think that this asymptomatic patient who's healthy may have dextrocardia, or a right-sided heart. And this can potentially be a normal variant, or sometimes it can be associated with a syndrome that includes some more pathologic features of other organs. So the first thing that you can do is a right-sided ECG to see if you have a normalization of voltages in the expected positions. But obviously you would want to follow this up with a chest x-ray and potentially a cardiac ultrasound to determine if the patient truly does have dextrocardia and what the ramifications might be for them clinically.